Most doctors receive only about 2 hours of sleep medicine education during medical school, which is crazy because all of our patients have to sleep. So if you are a physician, healthcare practitioner, or therapist, then go ahead and subscribe to this channel if you're ready to up-level your sleep medicine knowledge. And in today's video, I'm going to be talking about the things that I wish that every doctor knew about sleep medicine. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine. So before we jump into the video, I'd like to invite you to get my free sleep guide for outpatient doctors. It is a mini course filled with lots of great tools, pearls, actionable tips that you can use in your clinical practice today. So you can grab that at intrabalance.com/doctors, and then the link is also shown on the screen. So I'm going to be sharing 5 things that I wish that every doctor knew about sleep medicine. The first thing is that there are many different sleep disorders. So here's a little pop quiz. How many sleep disorders do you think there are? Do you think there are A, 14, B, 83, C, 57, or D, 28? Take a guess. So when I ask this during lectures, sometimes people get it, but oftentimes people don't actually guess the right number, which is there are 83 different sleep disorders. So this is important because insomnia isn't always just insomnia. You can't just take it as that at face value. It's really important to understand that there are lots of causes for people to have sleep issues. So with your patients, keep in mind that there are 83 different sleep disorders, plus other things, medical issues, gut health issues, emotional, psychological, psychosocial stressors. So many different things can contribute to sleep issues. So if we're just trying to match up an intervention with the symptoms without understanding the root causes, we're not going to help our patients get very far. So doing a thorough assessment with your patients in clinic, which I explain how to do in my free sleep mini course, is an important first step. The second thing that I wish more doctors knew about sleep medicine is that sleep apnea shows up very differently in women than it does in men. Before menopause, sleep apnea or obstructive sleep apnea is more common in men than it is in women, but after menopause, the numbers are roughly equal. The numbers skyrocket in women after they go through menopause. But obstructive sleep apnea can show up very differently in women and is often undiagnosed or misdiagnosed. In women, it can show up more as chronic fatigue, chronic aches and pains, depression, anxiety, irritability, problems with concentration. So it may get labeled as fibromyalgia or depression when there's actually an issue with sleep disordered breathing. An important note here is that with women, even if they have more mild sleep apnea based on their AHI or their apnea-hypopnea index, they can have more severe consequences like cardiovascular consequences over time than men with a similar AHI. If you're working with female patients, have a low threshold to screen them and even potentially do a sleep study on them if you even suspect there might be sleep disordered breathing. Because sleep apnea doesn't always show up in the archetype that we typically think of the obese male with a thick neck, it can show up in thin people as well. If information like this is helpful for you, then go ahead and click the like button. The third thing that I wish that more doctors knew about sleep medicine is that sleep issues are highly treatable without medications. But it all starts with identifying the root causes and then following a roadmap to identify and treat those root causes. And so in my course, The Holistic Sleep Reset, it's a self-guided course for sleep issues. I kind of go through a roadmap. But there are 4 pillars to think about to give yourself a framework when it comes to helping your patients sleep better. And these 4 pillars are identifying the root causes, looking at their circadian rhythm and getting that regulated, helping them to increase their sleep drive, and then helping them address their mindset and their relationship with sleep. And ultimately, that's really about reducing the hyperarousal response that perpetuates issues with insomnia. So here, circadian rhythm disorders may get misdiagnosed as insomnia, but another important point is that sleep quality is sometimes more important than sleep quantity. Supplements can also be helpful for certain types of sleep issues. For example, magnesium can actually be helpful in certain patients, especially patients who are taking PPIs or proton pump inhibitors. Passion flower may be helpful for women experiencing vasomotor symptoms from menopause. Supplements aren't just something you want to throw at the issue. You want to understand what you're treating and why you're using them. The fourth thing I wish more doctors knew about sleep medicine is that you can actually get a lot of good information from lab work, especially blood tests like vitamin D, iron levels, ferritin levels, vitamin B12, and so forth. And these are really easy to check in your patients. And you want to just make sure that you're checking these levels the right way, and again, for the right reasons. For example, if you have patients who have symptoms of RLS or restless leg syndrome, you'll want to be checking fasting iron and ferritin levels and doing a full panel. And so you can see my video on restless leg syndrome to learn more about how to appropriately check iron levels in these patients. And then the fifth thing that I wish more doctors knew about sleep medicine is that CBT-I, or cognitive behavioral therapy for insomnia, works. It is the first line gold standard treatment for chronic insomnia, and it is not the same as sleep hygiene. Sleep hygiene alone does not work for chronic insomnia. Sleep hygiene is a component of CBT-I, but CBT-I is much more than that. And it can be hard to find a CBT-I practitioner because there simply are just not enough sleep specialists out there to treat all of the patients. Again, all of our patients have to sleep. And so that's actually one of the reasons that I started creating this content to put out there, because there just aren't enough of us sleep doctors to see all of the patients. So it's important that as physicians and therapists, you educate yourselves on how to really get to the root causes and help your patients treat sleep in a really deep and fundamental way. So anyway, I'll get off my soapbox now, because CBT-I is very helpful. It can be done in an individual setting, one-on-one with a therapist. It can be done in a group setting, and it can also be done online via an app. There's lots of great resources out there, and I also have some videos on CBT-I if you want to learn more about that. I'm also coming out with a clinical sleep kit for physicians and therapists that they can use in their clinical practice that just will have loads of resources that you can use, including where to do CBT-I, the different programs that are out there, what the different programs cost, which patients are better for the various programs, and so forth. And so if you want to learn more about that sleep kit, again, you can go to intrabalance.com/doctors to learn more. Most doctors receive only about 2 hours of sleep medicine education during medical school, which is crazy because all of our patients have to sleep. So if you are a physician, healthcare practitioner, or therapist, then go ahead and subscribe to this channel if you're ready to up-level your sleep medicine knowledge.